Good afternoon, everybody. Thank you so much for having me. And I particularly like to thank the organizers for inviting me to share with you what I've learned over the last few years. As a nephrologist at University of Utah, it's been a very exciting time since the MRA study came out in 2015. We now have tools that we haven't had since the Captopril study came out in 1993. So for both cardiologists and nephrologists, this has been a revolutionary time, and I'm particularly delighted to be here today to really share with you my passion on particularly the first topic, the SGLT2 inhibitors, as it relates to cardiorenal protection. So my disclosures for this talk is really not relevant. What I'd like to do over the next hour or so is to really spend the first segment on SGLT2 inhibitors. I'll be discussing the mechanisms, but I'll be spending quite a bit of time talking about what the clinical trials have shown, and particularly as it relates to different patient characteristics at baseline that may have some impact on the benefits of this class of medication. I'll follow that by the glucagon-like peptide-1 receptor agonist, or GLIP-1 receptor agonist, and also touch briefly on the mineralocorticoid receptor antagonists, or MRAs. And I'm going to be spending a little bit more time on the new non-steroidal medication, the third generation finerenone, as the Fidelio and Figaro studies have been just published in New England Journal of Medicine, and I think it's important to understand the significance of these two trials. So I'll end with summary and a proposed algorithm to how to incorporate these novel agents to maximize cardiorenal protection. All right, so let me start by giving you a brief historical context. In 1993, the major landmark study, the Captopril study, was published in New England Journal of Medicine. This was the very first study to ever show that an ACE inhibitor can result in significant 43% reduction of doubling of creatinine, or 46% reduction in the hard endpoint of dialysis or transplant in type 1 diabetic patients. This was really earth-shattering at the point because we really didn't have any tools in 1993 other than treating diabetes itself and hypertension. This was then quickly followed by the counterpart studies in type 2 diabetics using angiotensin receptor blockers, Renal and IDNT, obviously this led to a risk reduction of 16 to 20% in the composite renal endpoint of doubling serum creatinine and stage kidney disease or death. But this is now in 2001, and since then, we've really had no progress, really nothing more to add to the toolbox. And so this has been very exciting, again, as I said, to understand that SGLT2 inhibitors now present probably the most powerful tool we've ever had in this field. And I cannot really dampen down the enthusiasm for this class. And I hope that by the end of the talk that you'll share some of my enthusiasm for this. Now, this is the first class of medication to target the kidney, ideally, initially, to really control glycemia. And so let's talk a little bit about how the kidneys handle the glucose. Vast majority of the filtered glucose, 97% of it, is reabsorbed by sodium glucose cotransporter 2, which is located in S1, S2 segment of proximal nephron. Whatever is remaining is then reabsorbed by SGLT1 in the S3 segment of the proximal nephron. Now, this effect of proximal sodium resorption is actually quite critical to the tubular glomerular feedback system, which is integral to maintaining stable GFR. So under normal physiologic conditions, if there is a conditional increase in GFR, that let's say you just had a pizza or you had a large sodium load, and you have increased sodium delivery to the distal nephron, that's going to be sensed by the juxtaglomerular apparatus, which will then lead to constriction of the afferent arteriole to normalize or reduce the GFR back down to normal range. That is the tubular glomerular feedback system, and that is critical from maintaining or from preventing GFR to go too low or too high. Now, what happens in early stages of diabetic nephropathy is that you have hyperinsulinemia and hyperfiltration that is sustained in a pathologic manner. Because of that also, SGLT2 is upregulated, and there's an increased absorption of sodium and glucose in the proximal nephron. What that means is that there's a decreased delivery of sodium to the distal nephron, which then means instead of actually reducing the arteriolar diameter to reduce this hyperfiltration, because of this lower concentration of sodium delivery to the distal nephron, it actually leads to dilatation of the afferent arteriole. So it sustains this pathologic hyperfiltration. And as you know, hyperfiltration is what leads to glomerular sclerosis, and it's a very critical component of diabetic nephropathy. So this is a huge problem. And in fact, the higher the GFR in early phase of diabetic kidney disease, the more worried I become, because it predicts glomerular sclerosis from this maintained hyperfiltration. So it is ingenious to block this SGLT2 with inhibitors such as empagliflozin or dapagliflozin. And when you do that, what will happen is that you stop the resorption of sodium and glucose, you increase sodium delivery to the distal nephron, and so then that signals the afferent arteriole to be constricted, and it will reduce the GFR, thereby reducing the hyperfiltration and protecting the kidney over long haul. So this very dynamic effect on the hemodynamics of glomerular structure is exactly why you see a dip in the GFR when you initially start this class of medication. Now, in clinical trials, about a third of the patients tend to increase their creatinine or dip their GFR, and in some cases, it can be as severe as 30% reduction from baseline. But what happens is that this GFR then improves, maybe not all the way to the baseline, but after about several months, or typically about a year, you see that the slope line ends up crossing over from that of placebo. And see, the overall result is that the slope of the GFR decline rate slows down. So this initial dip, which doesn't happen in everybody, but it commonly does occur, is really exactly as expected as you would see in ACE inhibitor or ARB, where you dilate the efferent arteriole and thereby reducing the GFR. It's the same hemodynamic effect, just using a different arteriole. And this is actually protective. This is not pathologic. Now, in addition to this glomerular hemodynamic effect, SGLT2 inhibitors also have very significant impact on the proximal nephron itself. You might have heard or seen that as the GFR goes down, the glycosuria goes down. So you would expect that there will be a minimal natriuretic or diuretic effect with SGLT2 inhibitors as you approach CKD4. Well, that is not what we see. Even though there is a decreased glycosuria, you actually have quite preserved natriuretic and diuretic effect of SGLT2 inhibitors, even in eGFR range of 20s. So how does that happen? Well, that has a lot to do with first realizing that in the proximal nephron, most sodium is reabsorbed not by SGLT2, but by sodium hydrogen exchangers 3, NHE3. Now, the SGLT2 and NHE3 are interlinked structurally and functionally. So activation of SGLT2 also leads to increased activity of NHE3, as in hyperglycemic conditions. It also is linked to a variety of other transporters, such as a uric acid transporter. And so activation of SGLT2 leads to activation of the other transporters that may be important in maintaining your electrolytes and different molecules. So when you inhibit the SGLT2 with, say, empagliflozin, you not only inhibit SGLT2, but you also inhibit NHE3. And so this widespread mechanism is probably what really explains why you have sustained natriuretic effect of SGLT2 inhibitors, even in very low GFR. Now, as I mentioned, SGLT2 inhibitors also block the urate co-transporter. So there is a very consistent uricosuric effect of this class of medication, and it tends to lower the serum uric acid by 0.75 milligrams per deciliter, and that may be a contributory factor for cardiovascular protection. All right, so how do we put together all the benefits that we've seen, which I'm gonna get into in the next few slides? We've seen protection from heart failure, from death, from kidney failure. How does this happen? From a medication that just blocks glucose and sodium resorption in the proximal nephron. Well, there are increasing amount of data to suggest that SGLT2 inhibitors also have direct effects on the myocardium, and it may improve the mitochondrial function, improve contractility and myocardial function altogether, and that may lead to improved renal perfusion and have the kidney be more resistant to hypoxic injury. It also, we know that SGLT2 inhibitors decrease insulin levels, increase glucagon, increases fatty acid oxidation, and increases the production of ketone bodies, which are better, more efficient fuel substrate compared to free fatty acids. And that has been associated with improved mitochondrial function in very high energy requiring organs like the kidney and the heart. So improved energy metabolism may also be an important role of their benefits. There are also some studies showing that SGLT2 inhibitors induce hypoxia-inducible factor, which leads to upregulation of erythropoietin. And you may have read in a lot of clinical studies, the hemoglobin tends to go up in this therapy. And there are also other effects, beneficial effects on the endothelium, on vasculature, anti-inflammatory, anti-fibrotic effects. So there are many pathways which may be triggered to result in a very potent cardiorenal protection. So let's actually talk about the clinical trials. What have we found? So I wanted to give you sort of a bird's eye view of the major clinical trials. This is not an exhaustive list by all means, but I wanted to organize it so that you see the specific CKD studies, the cardiovascular outcomes, and the heart failure specific outcomes trials. And what I want you to note here is that there were, with the exception of the CKD trials, the Credence and DAPA-CKD, remaining clinical trials really recruited patients who had preserved GFR, so at least CKD2 with GFR above 60. They had varying prevalence of heart failure at baseline, atherosclerotic cardiovascular disease. Most of them were maximized on ACE inhibitors or ARB therapy already. So these were really getting standardized therapy at baseline. And what I want you to note is look at the consistent benefit, roughly 30% risk reduction in all clinical trials for heart failure hospitalization. And you have up to 20% risk reduction in cardiovascular death. And when you come to the composite renal endpoint, which is really the hard endpoints of hitting end-stage renal disease or a drop in GFR, we're talking up to 40% risk reduction. This is on top of ACE inhibitors or ARB. We have never seen any drug class that can do this. So I want to talk to you about this exciting new study that is going to be published in the near future. AMPA kidney study is the largest CKD dedicated study using empagliflozin with over 6,000 patients here. The interesting to note here, this recruited patients down to eGFR of 20. DAPA-CKD study recruited down to 25. So by far, this trial has the sickest patients in terms of GFR range, with 34% of the participants having GFR less than 30, so CKD4. They also, unlike the other trials, recruited quite a few number of patients who did not have any albuminuria. The other two, the Credence and DAPA-CKD, required albuminuria as an entry criteria, at least 200 milligrams. Now, 20% in this study of over 6,000 patients do not have albuminuria. So we'll have a lot more data about the effect of SGLT2 inhibitor on patients who have no albuminuria after this study results are published. Now, the important, exciting thing is that the study was stopped just last month because of overwhelming efficacy. So this is a recurring theme with SGLT2 inhibitors. Studies, many of them get stopped early because of overwhelming efficacy. And so you're going to be seeing publication of this study result in the near future, so look out for it. All right, so I want to spend just a couple seconds on DAPA-CKD because this was the first dedicated CKD clinical study that included non-diabetic patients, all right? So as you can see, after just a median of 2.4 years, 39% risk reduction in the composite renal endpoints here. Pretty impressive. This is on top of the ACE inhibitors. And the benefit was really equivalent in diabetics or non-diabetics. So this is not a diabetic drug. This is really a kidney drug. Importantly, whether you have atherosclerotic disease or not, the benefit did not seem to matter. So this is going to be different from the GLIP-1 receptor agonist, where the benefit seems to be more restricted to patients who have history of vascular disease. In addition, whether you have heart failure or not, doesn't matter which endpoint you look at in the renal outcomes, really the benefit is same. So you don't have to have heart failure to have the benefit with this class of medication. Now, what about albuminuria? Patients have had varying levels of albuminuria at baseline. Does that matter when it comes to benefit? Well, the answer is yes and no. This is from Canvas, 10,000 patients with type 2 diabetes. And while the majority of patients did not have any albuminuria, about 20% did have microalbuminuria up to 300 milligrams, and about 760 patients had greater than 300 milligrams per gram of albuminuria. So if you look at the data, at the y-axis here is the eGFR slope decline rate, and this is stratified by the baseline albuminuria. If you look at those who did not have any albuminuria, you can still see that the group that received canagliflozin actually did better in terms of GFR decline. But as you can see, in every group, the decline rate was less in patients who received canagliflozin. But the benefit was indeed greatest in patients who had higher degree of albuminuria. So the answer is yes, it is consistent benefit across all spectrum of albuminuria, but the benefit is greatest or maybe greatest in those who have greater degree of albuminuria at baseline. What about GFR? What about very low GFR at baseline? Now, I mentioned earlier that you have this initial dip in GFR, and there's a concern if you have very significant CKD with a GFR level below 30, that because of this dip and your GFR doesn't actually get back up to baseline for a while, or perhaps it really takes about a year or so before you start crossing over with the placebo in terms of the decline rate. If you have very low GFR at baseline, could this push you toward to dialysis sooner and therefore unwarranted in those patients with very severe CKD? That's always been a question for nephrologists. Well, here's the answer to that question. This is a secondary analysis from DAPA-CKD. Remember, this clinical trial occurred down to GFR of 25. And what you're seeing here is that initial dip in the CKD2-3 versus CKD4, you are seeing that the acute effect actually is less in terms of GFR drop. And if you look at the chronic effect in both CKD2-3 versus 4, again, you see that the patients with more severe CKD at baseline actually had more favorable decline rate, less decline rate than the patient who actually had better GFR at baseline. So if anything, not only is it effective in CKD4, it may actually be more beneficial. And it is encouraging that we found exactly the same result in Credence, which recruited down to GFR 30. And here you are seeing that initial dip in patients who had the lowest GFR at baseline, and you can see the dip is less than the higher GFR groups, and their slope crosses over with the placebo at 8.7 months compared to 11 and 14 months in patients with higher GFR at baseline. So I think this is very consistent finding that the lower the GFR, the greater the albuminuria at baseline, the greater the benefit, not less. All right. Was there any safety signal in patients with CKD4 or CKD or patients with GFR less than 30 as opposed to above 30? And really, there were really no symptom difference at all. So it seems to be just as safe and most likely more beneficial. All right, so let's briefly talk about the heart failure outcomes with SGLT2 inhibitors. I want you to note that the cardiovascular death was reduced by 38% in MRA study, the first study that was published. And much of that was driven by preventing worsening heart failure, 75% risk reduction. Pretty impressive, all right? So it's no surprise that there have been dedicated heart failure outcome studies. Now, I wanna first talk about the 2 clinical trials focused on heart failure with reduced ejection fraction. So that's Emperor reduced and DAPA heart failure studies. And what you want to note here is that about half the patients had diabetes and ischemic cardiomyopathy. And these were sick patients. About a third of them had hospitalization within the 12 months. More than a third had atrial fibrillation, and their GFR rate is really preserved around 60. The other thing that's really of note here is that 70% were on a RAS inhibitor, and 20% of them were really with a renin inhibitor, another 70% on mineralocorticoid receptor agonists. So quite a few of the patients were actually on ACE inhibitor plus spironolactone or Clarinone, or some variation on that theme. So these were patients who were maximally treated on optimal standard therapy. So what happened in DAPA heart failure? Resounding success, a positive finding of 26% risk reduction in a composite of worsening heart failure or death from cardiovascular causes. And again, you see this very consistent 30% risk reduction in heart failure hospitalization. What about Emperor reduced? Very similar finding, 25% risk reduction in the composite outcome. Again, 30% risk reduction in heart failure hospitalization. This is almost, you could not make this be more consistent. Now, Emperor preserved was the first dedicated study to look at those patients with heart failure with preserved ejection fraction. These were still probably the first study to actually be positive, with 21% risk reduction here. This may seem lower than the other study, but if you may remember, none of the studies in the HFpEF patient population have turned out to be positive. So this was really taken by the experts to be a very successful clinical trial. All right, so in summary, there are consistent renal and heart failure benefits, including both for HFrEF and HFpEF patient populations in clinical trials. The renal benefit seems to take a bit longer to manifest itself. I showed you that it takes around 12 months for the decline GFR slope to cross over without a placebo arm. But when you talk about heart failure endpoint, the Kaplan-Meier curves split almost immediately. And so you start seeing the benefit within the first 3 months or so, which is really, I think, unseen in other drug therapy as well. So this is a very important finding. The renal composite endpoint consistently reduced by almost 40%. And remember that dip in the eGFR in the early phase is not something you need to worry about. And the benefit from this class of medication is not determined by whether you dip or not, or even the degree of the dip itself. I've talked about the heart failure benefit, and the benefit is maintained whether you have atherosclerotic cardiovascular disease or heart failure at baseline. So this is good for both primary and secondary prevention. Greater benefit in those patients with greater degree of proteinuria and CKD. All right, and safety seems to be very similar in both CKD3 and 4. So let me actually give you a quick warning about this adverse events and how you might want to prescribe this class of medication, because when you're not used to it, it's always more anxiety provoking. So the more you understand, the more comfortable you get in prescribing this class of medication. So the most important and serious side effect is increased risk of diabetic ketoacidosis, which can be euglycemic. But really, once we've had a lot of clinical trials and there are a lot of meta-analysis looking at safety endpoints, really the main risk is the diabetic ketoacidosis in diabetic patients, not so much in non-diabetic. In DAPA-CKD, there were no DKA in the non-diabetic arm. Now, probably the most common, fortunately DKA remains quite rare still. The mycotic genital infection, not UTI, is really probably the most common problem. But typically, this is quickly resolvable with one dose of diflucan. So this is no reason to shy away from this class of medication. The volume depletion is by design. It's really not an adverse effect. It's actually the intended effect of the drug because it has the natriuretic diuretic effect. And this just has to be cautious when you start patients with lower GFR so that they don't get a prerenal injury. Fracture and amputation were only seen in Canvas trial. So general strategy, I actually spend quite a bit of time every time I start a patient on SGLT2 inhibitor to make sure that they understand that their creatinine may bump initially and that it's important not to panic over that. The other thing I tell them is it's very important to maintain good hydration because this may have a volume depletion effect. And I tell them to hold the drug if they have any acute illness or for any hospitalization so that you don't actually increased risk of the DKA if you were to get into a fasting state, particularly in diabetic patients. So you just have them hold it if they have any nausea, vomiting, diarrhea, or acute illness like flu, and then restart when they're back to their baseline. You definitely want to be holding it for these conditions. In fact, if you develop DKA, you probably is contraindicated for restarting it, unless it's really going to be a case-by-case basis. So I've really gone over that. So let me actually then talk about the glucagon-like peptide 1 receptor agonist, GLIP-1A. Now, the GLIP-1 is a peptide hormone that is produced in the intestine in response to a meal to enhance secretion of insulin and reduce glucagon release. Now, it's important to remember the receptor for GLIP-1 is actually expressed in a variety of tissues, including the brain, particularly the hypothalamus, where the satiety and appetite control center is located, the kidney, cardiovascular system, including the endothelium and the heart. And so GLIP-1 actually has a variety of effects outside of the gut system. And the proposed mechanism for benefits, although some of these are somewhat controversial, is that when you increase insulin in response to a meal, you're going to reduce the postprandial hyperglycemia and improve glycemic control. Through the receptors in the cardiovascular system, you may have protective effects on the cardiovascular system. And by inducing the early satiety and decreasing appetite, we know that this class of medication causes most impressive weight loss. And at the kidney level, it tends to promote diuresis by activating NHE and reducing hypertension. So these are some of the proposed mechanisms, although the underlying exact mechanisms are still really not very clear. The problem with GLIP-1 is that they're very short-lived. They're rapidly degraded by dipeptidyl peptidase 4, DPP4. So if you want to prolong the action of GLIP-1, you either inhibit this inhibitory enzyme with the DPP4 inhibitors, like the gliptins, or you create an agonist to prolong the action through the GLIP-1 receptor agonist, which is really the topic of this segment. All right. Now, of all the diabetic drugs that have been developed, GLIP-1 receptor agonists are somewhat unique in the sense that the agents in this class are very heterogeneous. So one agent under the same class is not equivalent to another, and you have to be careful of which agent you choose for what purpose. Now, the short-acting and long-acting are really probably the easiest way to break them down. And what you note here is that the long-acting, which really has shown all the benefits that we're going to be talking about shortly, also seems to have a better, more potent effect on metabolic profile in terms of reducing glucose and possibly less side effect profile. So it's important to keep that in mind. If you want to compare the metabolic effects on various parameters by GLIP-1 receptor agonists versus DPP4 inhibitors, it's interesting that these two classes actually really are aiming at the same pathway, and yet they have very different results. So if you're talking about A1C reduction, GLIP-1 agonists can reduce it up to 1.8, in some point almost 2%, which is really unheard of in other class medications, clearly far better than DPP4 inhibitors. The blood pressure lowering effect is very modest, maybe 2 to 5, and it has favorable effects on the lipids, compared to the DPP-4 inhibitors. But by far, probably the best use of this class of medication is the weight loss, which can be on average of about 5 kilos. But in some patients, it can be almost miraculously a high amount that they can lose on this class of medications. So I don't think there's any other class of medications that can compete with that in the diabetes literature. So what about the cardiovascular outcomes? Here, GLIP-1 receptor agonists, really depending on which agent it is and how the patients were selected, there have been some variable results. But overall, if you look at different meta-analysis, there have been consistent 12 to 14% risk reduction in MACE, which are cardiovascular deaths, non-fatal MI, and non-fatal stroke. It has not led to a significant reduction in heart failure hospitalization, however. If you look at the results of the MACE, again, this was the point, unlike the SGLT2 inhibitors, the benefit on MACE seems to be restricted to those who already have history of cardiovascular disease, and not so much in those people who are naive to cardiovascular disease. Now, what about the renal endpoints? Yes, there was a 17% risk reduction in the composite renal endpoint here, but this was entirely driven by reduction in macroalbuminuria. It had no impact on actual GFR reduction, slowing down a progression to end-stage renal disease. So it is still unknown to this day if GLP-1 receptor agonists can actually slow the progression to end-stage renal disease, unlike in the case of SGLT2 inhibitors. So one quick word about using this class of medication in CKD, particularly in severe CKD. So there are very limited data in this patient population. I'm a nephrologist, so I have to gear toward CKD here. So you can see that liraglutide, dulaglutide, and semaglutide actually do have renal and cardiovascular protective benefits, as well as documented safety in patients with GFR as low as 15. So if you're going to start GLP-1 agonists in CKD4 patients, one of the 3 agents would be your choice. The others really should not be considered in severe CKD for safety reasons. And in fact, the short acting is actually limited by the kidneys, so you really want to avoid that below 30. And again, for the long-acting agents, remember that these are not excreted by the kidneys, so you do not need to adjust the dose in CKD4. So let me summarize what I've said about the GLP-1 receptor agonist. Here, unlike the SGLT2 inhibitors, which really seems to be pretty consistent regardless of which agent you choose, with GLP-1 receptor agonists, it's important to choose the long-acting, not the short-acting. And there has been consistent 12% risk reduction, a modest reduction in MACE, and a modest reduction in albuminuria, but no change in actual GFR loss. So that's in contrast to SGLT2 inhibitors, and again, no effect on heart failure hospitalization overall. Now, in contrast to that, DPP-4 inhibitors actually have been shown to be associated with increased risk of heart failure. So yes, you can use DPP-4 inhibitor for lowering glycemia, but not for cardiorenal protection. All right, so let me get on to the last topic, the mineralocorticoid receptor antagonists. So we have known for decades that sustained increase in aldosterone level or mineralocorticoid activation is very deleterious for cardiovascular system and also on the kidneys. We know that at the level of the kidney, aldosterone upregulates ENaC, the epithelial sodium channel in the collecting duct. It very potently increases sodium absorption, leading to hypervolemia and hypertension. It also activates sympathetic activity and really activates in a powerful way pro-fibrotic and pro-inflammatory pathways. And so there have been very close association of development of myocardial hypertrophy, ventricular remodeling, and increased risk of arrhythmia with increased aldosterone level. And at the level of the kidney, glomerular hypertrophy, glomerulosclerosis, and reduction in kidney function have been attributed to excess aldosterone levels that is sustained. So it is no surprise that there have been long years in coming to search for that perfect mineralocorticoid receptor blocker. Now, we started it with spironolactone back in 1960, although you might note that it took almost 40 years for the very first landmark study to be published in heart failure patients. And I'm going to talk a little bit more about the RAIL study in the next slide. And then, of course, in 2002, we had the second generation of eplerenone, which was more specific to mineralocorticoid receptor. And we'll talk a little bit more about that. And various cardiovascular, mostly heart failure studies that have shown persistent benefit. Now, we now have the non-steroidal, the newest kid on the block, the third generation finerenone, and I'm going to be spending more time talking about this in the later slides. All right, now unlike the heart failure studies, there were multiple studies looking at the efficacy of MRAs in reducing hard endpoints in heart failure population. We as nephrologists haven't really had the same degree of clinical trials looking at hard renal endpoints using MRAs, unfortunately. There have been suggestive data looking at observational studies or subgroup analyses or secondary post-hoc analyses, but really not the dedicated primary CKD outcomes trials. But we have had small studies looking at antiproteinuric effect of MRA. And it's important to sort of note, this is one of the important studies, small, 41 patients, both diabetic and non-diabetic, with about 2.5 grams of proteinuria. And the patients were randomized to 4 groups. Ramipril only, ACE inhibitor only, ACE inhibitor with an ARB, Ramipril with spironolactone, and then everything together in group 4. Here is the change by fraction in 24 urine protein excretion. So the reference here is the Ramipril group. When you added ARB to an ACE inhibitor, there was appreciable but not a very significant reduction in proteinuria. But when you add spironolactone to Ramipril, 42% additional reduction in proteinuria. Now, when you add irbesartan and spironolactone to an ACE inhibitor, the benefit is very, very small, and it's probably not worth the risk of hyperkalemia. So there's something different about inhibiting aldosterone that really gives you an additional benefit that you do not see by adding an ARB to an ACE inhibitor. And this has been very persistent in clinical studies looking at proteinuria as an endpoint. What about in cardiovascular studies? Well, there have been multiple, and I already mentioned the very first landmark study, the RAILs, that was published in 1999, was looking at the efficacy of spironolactone to reduce all-cause mortality and heart failure hospitalization in patients with severe heart failure with reduced ejection fraction. And these patients were already maximized on their ACE inhibitors and diuretics. 30% risk reduction in all-cause mortality, 35% risk reduction. And I'm sure you remember that when this trial came out, it made quite a splash. Now, following that, there have been more studies using eplerenone in different patient populations, sometimes involving acute MI or milder heart failure, with persistently significant risk reduction for the cardiovascular endpoints. The exception has been the TOP-CAT study, which was the only really study to look at heart failure with preserved ejection fraction. And here there was a trend for benefit with spironolactone, but it did not meet statistical significance. Now, there are 2 important points that I want you to take home on this table. One, the benefit that you're seeing here when you add a mineralocorticoid receptor blocker to an ACE inhibitor is something you do not see when you just add an ARB to an ACE inhibitor. So again, there's something different about inhibiting aldosterone that is different from just adding an ARB to an ACE inhibitor when it comes to heart failure endpoints and to continue on to proteinuric effect as well, antiproteinuric effect as well. The problem, the second point, is really not the efficacy, it's been safety. So, soon after the RAIL study got published, there was a significant uptake in prescription of spironolactone, and unfortunately, so did the in-hospital deaths from hyperkalemia. So this unfortunately dimmed any enthusiasm that you had for using spironolactone or mineralocorticoid receptor blocker to treat heart failure. And so there was an increasing need to come up with something that's safer, that might be just as effective, that could be used when you have exhausted all other resources. So let's talk about the differences. Spironolactone is the first generation steroidal receptor. It has a very potent anti-mineralocortical receptor activity, but it does not have much selectivity. So it will inhibit androgen receptor. It will actually induce progesterone receptor. So men tend to get gynecomastia and impotence. Women can get amenorrhea. These are not acceptable side effects at higher doses. In addition, the distribution of this spironolactone is much more heavily geared toward kidney as opposed to heart. So you do have an impressive blood pressure lowering effect, but you also have more effect on increasing potassium level and causing more severe hyperkalemia. The second generation of eplerenone has gained on the selectivity, but lost out on the potency. So now we have this non-steroidal finerenone, the third generation of MRA, and it not only has it regained the potency against the mineralocortical receptor, it is over 500-fold more selective for the MR than other steroid receptors. So you can forget about the side effects such as gynecomastia, impotence, or amenorrhea, because it is not likely to engage those other steroid receptors. The other important difference is that it is more evenly distributed between the kidney and the heart. So you are less likely to get hypotensive effect. In fact, it's quite minimal. You do not want to be using this for hypertensive patients if that's your goal. But it also means that it will have less hyperkalemic risk. All right, so what have we found? This is the Fidelio diabetic kidney disease study that was published in New England Journal of Medicine a couple years ago. Now, I want to make a bit of a fuss about this study because this is, I think, a major landmark study to really dedicate to CKD endpoints using an MRA, in this case, the finerenone. All right, so these were patients who were type 2 diabetics with chronic kidney disease, CKD3 at baseline, with non-nephrotic but significant albuminuria at baseline. Now, after a mean follow-up of 2.6 years, you can see 18% risk reduction in the overall composite renal endpoint of kidney failure, 40% loss in GFR, or renal death. And this the component of this primary endpoint were pretty well matched, 19% risk reduction and increase of GFR, loss of GFR, and 13% reduction in renal failure and 24% reduction in renal secondary composite endpoints. Now, what about proteinuria? There was 31% reduction of albuminuria compared to the placebo. So again, this is on top of the maximal ACE inhibitor therapy. So this is really on par with the spironolactone in terms of anti-proteinuric effect. When you're looking at the potassium safety profile, obviously we care about that. Yes, there were increased risk of hyperkalemia, and overall the hyperkalemia-related adverse events were twice as frequent as the placebo arm. And maximal potassium difference occurred at month 4 by the amount of 0.23 millimoles per liter. Now, if you care about the severe hyperkalemia of 5.5 and 6, the finerenone group had nearly 2 to 3 times the rate of the placebo in that. But I do want you to take on this important message. Hyperkalemia that's severe enough to stop the drug was rather infrequent. It occurred in 2.3% of the patients. Now, in comparison, in REL study, it happened in 8% of the patients. And in other studies that are mixing ACE inhibitors, ARBs, or ACE inhibitor with renin inhibitor, the incidence really range between almost 5% to 9%. So it is a much smaller fraction of the patients who have to stop the drug because of hyperkalemia. So indeed, it does seem to be safer on that remote. And as I mentioned earlier, the change in systolic blood pressure was quite minimal, only 2 to 3 points. All right, I want to talk about the sister study, the Figaro. We just talked about Fidelio. The Figaro study was really another landmark study looking at incident heart failure as the endpoint. And again, type 2 diabetic patients with albuminuria maximized on ACE or ARB. Now, importantly, because it's an incidence study, only 8% of the cohort, there's over 7,000 patients, had history of heart failure. So vast majority of the patients in the study were naive patients when it comes to heart failure history. Again, they had better GFR than the Fidelio study and also lower albuminuria at baseline. And look, 32% risk reduction in new onset hospitalization for heart failure in those patients who didn't previously have it. So that's a pretty remarkable reduction in risk. And again, this I think is the very first study ever to show a reduction in incidence. So this actually can be used as a primary prevention of heart failure in type 2 diabetics with CKD. But when you look at the whole group, including those with the history of, the result was quite similar. So I would say this, like SGLT2 inhibitors, you could use it for both primary and secondary prevention of heart failure. All right, so to summarize what I talked about regarding mineralocorticoid receptor antagonists, the steroidal MRAs, the older first and second generation, are less selective to mineralocorticoid receptor and therefore have more side effect profile. And they also have heavier distribution to the kidney, causing more problem with hyperkalemia. But they do tend to have better antihypertensive effect. The non-steroidal MRA is much more specific to mineralocorticoid receptor, and therefore is expected to really give you none of those dreaded side effects related to other steroid receptors, and it is associated with less, but not zero, hyperkalemic risk. Right. And finerenone simply lowers the composite renal endpoint by 18%, compared it to almost 40% with SGLT2 inhibitors. This is on par with the renal and IDNT study effect size. And again, it also prevents incident heart failure by over 30%. So overall, if I were to sum it up this hour, I would say the SGLT2 inhibitors are the most powerful tools to hit the nephrology and cardiac world since ACE inhibitors. And it's really probably the best single protective agent for all comers when it comes to heart failure and CKD progression. It's important to remember that initial dip is not a reason to worry, and that doesn't determine the benefit of the drug. And in fact, the more severe the CKD level and greater the proteinuria, the probably greater the benefit. And we're going to be soon hearing about AMPA kidney study result, which is going to be really going down to eGFR of 20. I am getting a funding to study this in the dialysis patient population because they have the highest risk of sudden death and heart failure, and they've always been excluded from most of the clinical trials. So I think if anything, this may be the drug to hopefully reduce the risk of sudden death on the dialysis population, but that's going to be years away. Now, GLIP-1 receptor agonists are most powerful for weight loss and for having a modest reduction in MACE endpoint, but it does not seem to reduce GFR loss or heart failure hospitalization. Finerenone is another new kid on the block that seems to have a lot of promise. It does not have the antihypertensive effect that spironolactone does, but it seems to have much better safety profile, and it seems to be very effective in reducing incident heart failure and slowing down the CKD progression. But the effect size seems to be smaller than SGLT2 inhibitor. So how do we put this all together? Let me remind you again, the SGLT2 inhibitors and the GLIP-1 receptor agonists prevent progression to macroalbuminuria by 20 to 30% and reduce albuminuria by 30 to 40% in those patients who already have macroalbuminuria. And this is pretty similar to the effect that you see with finerenone and spironolactone as well. Now, there are no head-to-head clinical trials comparing efficacy of these different agents for cardiovascular and renal endpoints. So the overall recommendation is going to be really depend on the strength of individual clinical trial. And of note, there are no data regarding the efficacy of GLIP-1 receptor agonist or finerenone in non-diabetic patients, unlike SGLT2 inhibitors. All right, so let's put it all together. How do we actually put it together and strategize our medication use? So I've written, because this is really adapted from a C. Jason paper here. And I think with the exception of GLIP-1, you could probably apply this to heart failure patients or non-diabetic patients with CKD as well. So if you have a diabetic kidney disease patient who are maximized on ACE or ARB, and they have macroalbuminuria, but have GFR that is at least 20 and above, then the next drug, and in some cases, cardiology might argue that it should not be ACE or ARB, it should be SGLT2 first. SGLT2 inhibitors should really be at least be the second agent, if not first. Now, the other option, if this is not somehow doable, could very well be a mineralocortical receptor blocker, depending on what you also need to accomplish, whether the patient has hypertension that is uncontrolled, in which case spironolactone might be preferred over finerenone. If potassium is a big problem, then finerenone may be a better choice in that sense. Or GLIP-1 receptor agonist certainly is also effective at lowering proteinuria as well. If you have lower GFR than 20, obviously we don't have the safety data to start SGLT2 inhibitors at this time. You should note that in all of the randomized clinical trials, they never stop the SGLT2 inhibitors down to dialysis stage. So there are hundreds of patients on dialysis who are receiving SGLT2 inhibitors right now. We don't have any access to their data. The question, I think, is it safe to start SGLT2 inhibitor when you have GFR less than 20? It's a different matter from continuing it once you have started it. So we can't really recommend that you start SGLT2 inhibitor in those patients who have GFR less than 20, but you could start GLIP-1, one of these three agents, obviously, as we talked about, or possibly finerenone may be a good option there if potassium is not an issue. Now, if you don't have proteinuria, but you have a high risk of heart failure, by far, the first choice is going to be SGLT2 inhibitor, or possibly finerenone, but I would say SGLT2 inhibitor just because we have more data on that. If you have really no increased heart failure risk but atherosclerotic vascular disease, then you really have a very similar efficacy with SGLT2 inhibitors or GLIP-1 receptor agonists in reducing MACE endpoints by about 12 to 14%. So you could use either in that setting. Now, if you have microalbuminuria but don't have really increased cardiovascular risk and you have GFR at least at 20, then again, I would say the first choice there is SGLT2 inhibitor, with the others being a possible alternative. Again, finerenone versus spironolactone, depending on your blood pressure needs or the potassium issues. And of course, if you have lower GFR than 20, then again, as above, either GLIP-1 receptor agonist or finerenone or spironolactone. Now, if you don't have any increased cardiovascular risk, but you really have morbid obesity and you have huge metabolic burden, by far, the choice here is a GLIP-1 receptor agonist. There's no other drug that's going to help you lose the weight, really ameliorate the metabolic risk profile as the GLIP-1 receptor agonist. That's, I think, by far the winner in that case. And if you really don't have any of these, and you're just a very, very mild diabetic kidney disease without any proteinuria and everything else is standardized, you can probably sit tight and watch. So I think that's where I like to end, and I'm happy to take questions in the remaining time. Thank you.
Drop around, thanks, to normally drop around 30% in the first 4 weeks with the SGLT2 inhibitors.
Up to 30%.
I thought on one of your slides it said it was recommended to stop for a week if it drops more than 25%. I've had 2 patients that the nephrologist recommended they never go back on it, and so I just don't know. Is there a recommendation that to consider a retrial of that?
Sure. So typically what I do is I used to, when I was first starting, I used to always check creatinine within 2 to 3 weeks or at least within a month to see how much it bumped. If you look at the literature, the creatinine can bump quite a wide variability. So you can have almost no change to a 30% increase from the baseline. And if it's greater than 30%, that is rather unusual. And you have to look for other reasons. You want to make sure that you weren't titrating diuretics at the same time or having any kind of heart failure exacerbation. So you really have to look for other causes. SGLT2 shouldn't really cause that. And so if you have a significant increase up to 30%, you can stop. A lot of times what I do is I wait. If they're doing well and their blood pressure is well controlled, the patient feels really well, I usually just continue and recheck it within another 2 to 4 weeks. That's what I do. All right, everyone's gonna tell you something different. It's just really a matter of your comfort level. I don't stop. This is the best tool I have. So the reason that I would absolutely stop would be if they develop euglycemic diabetic ketoacidosis, or they have really high risk of genital infections that can give them sepsis and hospitalization risk, then I'll consider twice. But in terms of creatinine increase, yes, you can stop. I would always re-challenge after the creatinine goes back down. Remember with ACE inhibitors, the creatinine always goes back down. It's a hemodynamic effect. It's not an actual change in renal function. So if it is due to SGLT2 inhibitor, the creatinine should go back down. And then you can re-challenge. Now, if it goes back up to the same level, if the patient is feeling well and doesn't know that the creatinine is higher, you can't really tell it from the way the patient feels or looks, then you might want to just recheck it in another month. Give it a chance, because remember, it can take several weeks for that GFR to come back down. And remember, the GFR may never go back to the baseline range. It may be always a little lower. That's okay, as long as it doesn't keep fluctuating or worsening. So with SGLT2 inhibitors, you just got to sit tight and don't panic. The most important thing is, how is the patient feeling? If they feel good and you don't really see any other red flags, any other contributor to acute kidney injury, I would sit tight and just recheck within a month. That's what I would do.
Great. And then one other follow-up question out of left field. We talked a lot about the heart failure benefits. I think the MACE study was all-cause mortality, cardiovascular mortality. So what about diabetics? It's full of CAD and stent placement. Is there a difference between heart failure outcomes with SGLT2 inhibitors and then the GLP agonists as far as coronary artery disease and stents?
So very similar. So you're talking at MACE endpoints, about 12% risk reduction overall when you look at meta-analyses. That depending on which meta-analysis you're looking at and what trials were involved, included or not, you may see up to 14% risk reduction with GLIP-1 agonists on MACE endpoints. And that's very, very similar to what you see with SGLT2 inhibitors. So yes, SGLT2 inhibitors will reduce your MACE endpoints, the atherosclerotic cardiovascular events. It's just not as potent as the result on heart failure prevention or amelioration of hospitalization for heart failure. So that's what's really talked up. But yes, SGLT2 inhibitors do have positive benefit on atherosclerotic disease, and that's on par with GLIP-1 receptor agonists.
Perfect, thanks.
Okay. Other questions?
Yes. So I get a little bit confused with the, over here.
Sorry.
With the GLPs, because I've been detailed recently on an oral GLP versus the sub-Q.
Yeah.
Any ideas on that? Is it still long-acting? Does it still
Yeah,
follow
so
the
the
benefits?
oral agent is long-acting. Now, I'm not an endocrinologist. I don't tend to use these nearly as much as the endocrinologists. And I usually don't start this class of medication as much. I probably will start to do so. Again, it's about the comfort measure. But it's newer, so we don't have the same safety data for the CKD4, but I believe the benefits are pretty comparable with the oral agent that is long-acting.
Okay, thank you.
Yes, it's definitely more convenient for the patient. That's the semaglutide, yes.
Great. I'm going to steal one more question real quick. I wonder, we talked about primary prevention for heart failure, but what about primary prevention of CKD? Diabetic CKD. I mean, do you ever see any of these medications becoming before you get proteinuria?
We don't have any data. And also, I think the other big stumbling block is the cost. It's $500–600 a month. And it's a very variable cost depending on the insurance you carry. So I have to work a lot with the system program. But yeah, that's, I think, the major stumbling block here. Yeah.
With concern for euglycemic diabetic ketoacidosis, how do you counsel your patients who haven't had this before but could develop? Do you give them like urine, strips to test at home if they feel unwell? How do you talk to patients about that?
That's actually not a bad idea to give them a urine dipstick strip. In general, really, prevention is my main mode. So remember, in DAPA-CKD, patients who are not diabetic did not have any DKA. So this is a higher risk for the diabetic patient population. So I look at several things. Number one, make sure they don't get dehydrated. Make sure they hold the drug when they're acutely ill. Do not take it while you're sick. and don't skip around on insulin. Now, if you have a very well-controlled A1C closer to 7%, I'll reduce insulin by 20% before I start this agent because it can potentiate hypoglycemia. And so that's actually a separate issue. But the bottom line, I think, is really counseling them not to get dehydrated, not to skip the insulin doses. And then if they have any kind of vague abdominal symptoms and they don't feel well, that's when they really need to pay attention, either call me or go to the ER to get tested for ketones. But a urine strip actually would be a good idea in that setting, and that would probably prompt them to go to the ER if it's positive.
Thank you for your excellent discussion. Before this lecture, I'd never heard of finerenone. I'm familiar with spironolactone and eplerenone. I just pulled it up. Trade name Corindia is about the same cost, between $600 and $700 a month.
Yes, it's a brand new drug.
Yeah, my question is, would you use the other ones first? And if they had problems with hyperkalemia or gynecomastia, switch? Or how is it being covered?
Right.
insurance-wise?
I think this is the same question I had when the study came out. Is it worth can you justify the cost? And I think that's why I said, if you have a patient who's maximized and they're hypotension, borderline hypotensive, and you just cannot be adding a spironolactone, but they are at such high risk for heart failure, that's a situation where you might consider because it really has a minimal effect on blood pressure. And if those patients who are on multiple agents are running at low potassium of 5.2, for example, the addition, and you really don't have any more room to go up on the diuretics, you can start the patiromer, the potassium binders to allow addition of spironolactone. That could also be tried. In my experience, spironolactone down to up to 25 milligrams are really well tolerated. I think the main difference is that it's a very, very potent antihypertensive. It's my favorite antihypertensive drug, to be honest with you. That's what I go to, almost better than ACE inhibitors, unless I'm really trying to target hyperfiltration. So I think if the blood pressure is not an issue and you have room to go, then you can always start with spironolactone. You could even start at 12.5. And most people tolerate that really well without gynecomastia or impotence or amenorrhea. So it's the higher doses. I never go to 50 milligrams. The only time I actually up-titrate spironolactone is if you have a primary hyperaldosteronism, you titrate to potassium level, not blood pressure. If you actually have a decompensated cirrhosis with ascites, where you really need to maximally reduce aldosterone tone, that's when I'll get up to 200 milligrams. But for blood pressure control, for heart failure, I do not go beyond 25 milligrams, and usually it is pretty well tolerated. So it's really a sort of a balancing of the individual differences of where they are with their blood pressure, what is their hyperkalemic risk, understanding that finerenone does not get rid of the potassium risk altogether. It just lowers it. If I don't know if that answers it. Yeah. You had another question over here? Or?
I have one more.
Oh, yes.
Do you have time?
Okay.
Is there any role for replacing metformin with the SGLT2 receptor if there is renal failure or
So metformin versus GLIP-1 receptor agonist?
the SGLT2 receptor agonist
For what purpose?
for the protecting the kidneys? Were these studies done with metformin already on board?
So many of these patients, I think the diabetic patients probably were on metformin because that's one of the first line therapy to go to, right? So yes. And so, we don't have a study that compares. Metformin really has not been looked at for renal endpoints. So really can't comment on metformin as it relates to renal protection.
So maybe let me clarify. So suppose I have a patient who has diabetes and is on metformin, and then they develop some chronic kidney disease from the diabetes, but their A1C is adequately controlled on the metformin. Would it be worth replacing the metformin with the SGLT2 receptor inhibitor?
Yes.
Yes.
I would. That would be my first choice. Yes.